think today it's a very important meeting, and this meeting is important in quite a few aspects. One, when Ajanta Pharma, Dr. Kamal and Sushil asked me that can we have a symposium or a webinar on concepts of hypertension, I said yes, we can have. As we know that Ajanta Pharma markets antihypertensives as an interest in combinations of calcium antagonists and ARBs. But I said this should not be a product-based meeting. It should be a meeting where we can discuss among doctors new concepts that we see are emerging in 2021 in the treatment and management and outcome of hypertension, and how we can use this data. And of course, on the background of what kind of antihypertensive is being marketed in India. And Ajanta Pharma, Dr. Kamal and Dr. Sushil readily agreed to that. And that's why this symposium is taking place. What we would do is we will not delve on everything that we know about, but try to restrict to things that are new, look like new solutions and new challenges that has come in front of us in the maybe breaking in the last couple of years' time. We start with something different. So number one is something little different. That is a beautiful skyline of Mumbai. Okay, well, it might not be Mumbai. It might be New York. Why not London? Or maybe San Francisco? Anywhere. See, a city, when we look at a city during the daytime, it's just steel and concrete jutting out of earth. There is hardly any life visible there. So if you actually want to judge the character of the city, you need to observe the city at night, nightlife. So if you look into this picture, for example, the tourist-filled midnight, looking at the Arc de Triomphe, we know that it is Paris at midnight, right? And it's so very different if you look at this picture. This is Las Vegas at midnight, gambling at its full force inside those fabled casinos. And in contrast, if you look at this nightlife, you know, roadside trading, from textiles to vegetables to everything possible ongoing, you know that it is Mumbai. So all we're trying to tell you that what is not visible during daytime takes a different shape at night. And that's why they say, whether you're talking about a city or even true to life, nightlife is a good predictor. Nightlife is a good predictor. Now, with that background, understand that we have been talking about taking out blood pressure measurement out of office for a long period, not just the COVID of 1.5 years now, but even before that, understanding that the few seconds of interaction, the few seconds or a few minutes of interaction that we have with our patients who are in our outpatient department, in our clinic, in our hospital, they're angry, they're hungry, they're waiting for a long time, they're upset, is not a right time or an environment to look into the blood pressure. And we said that blood pressure measurement needs to get out of office and reach the patient's home. Now, how do we get home? Today, we have enough amount of experience with what we call as ambulatory blood pressure monitoring. So we put the instrument of ambulatory BP onto the patient goes home, and 24 hours later, we see how his blood pressure has been. The instrument intermittently measures the blood pressure and gives us a graph of 24-hour spread. And what a huge amount of data we have learned. Today, we also have something different. We call it home blood pressure measurement, where the instrument, patient puts himself and measure the blood pressure. It doesn't measure blood pressure at sleep, but can measure blood pressure at defined times when he is in the comfort zone of his home. So home blood pressure monitoring, ambulatory BP monitoring are ways whereby we have extended that brief period of interaction with the patient for blood pressure measurement to far more comfortable areas where we might get a real glimpse of the real life blood pressure and not just a snapshot in the clinic, right? But then If you actually look into the blood pressure, ambulatory blood pressure recording, we get a lot of knowledge beyond what we had discussed. For example, the top line is systolic blood pressure, bottom line is diastolic blood pressure. Those gray bands are the normal range. So you see that period is daytime, now morning 10 o'clock till about 9 o'clock, which is light color. Okay. And if you see morning blood pressure, this is basic to understand. Morning blood pressure is governed, determined, and under control of a sympathetic system, right? We are all sympathetic charged, right? I am now talking in front of a computer, right, to the people. So my sympathetic system is up and about. So when a patient sympathetic driven system comes to the hospital, his blood pressure tends to be higher. For some people, it's so high that we call it what? White coat hypertension or white coat effect. And that sympathetic drive goes down when he goes home. But the daytime BP overall is governed by sympathetic. There are hormones, there are volumes, there is salt sensitivity, but the sympathetic system dominates at a time when we are up and about and we are active. Now, as the day passes, that straight line, and we go to that straight line is at 9 o'clock, and the patient goes home and goes to bed, nighttime, the sympathetic system slowly comes down for most people, right? And as it comes down, you see that the blood pressure gradually drops at night, what we call as a night dipping of blood pressure. And as the patient goes to bed, the night blood pressure settles down. And as you see there, it is far lower than the daytime blood pressure. So daytime blood pressure governed by sympathetic. As we go home and go to bed, if you're comfortable, of course, the blood pressure comes down and sets at a lower level, nighttime blood pressure. And that nighttime blood pressure, early morning when we wake up, tends to go down, go up again, morning surge. So night, as we are sleeping, the blood pressure control from that sympathetic driven daytime is given over to renin-angiotensin system, volume state, and salt sensitivity. So are they not acting in daytime? Renin, volume, salt, yeah, they do act, but daytime sympathetic takes over the baseline, while at night, as the sympathetic is taken away, renin-angiotensin, volume drive, and salt sensitivity are the background hum that controls blood pressure. So that's why we say that if we look at the nighttime blood pressure, it is the basic background that we are looking at for a person. But then this is something we didn't expect. Now look at this data. This is from the Dublin outcome study. Look at this data where on the x-axis we have systolic blood pressure, 90, 120, 170, 230. Systolic blood pressure in x-axis, right? Look at the y-axis. It is the 5-year risk of cardiovascular death. So we are not talking about cardiovascular events. We are talking about a much harder endpoint, stronger endpoint of mortality, right? And on the x-axis is systolic blood pressure. Now let us say we are looking at the clinic BP in the lower line. Lower line is the clinic BP. Somebody has a blood pressure of 120 systolic and has a risk of, let us say, 1.00. Okay, baseline risk. His blood pressure now suddenly goes to 170. 170, severe hypertension, right? Now see, where does his risk go? As per as the clinic BP prediction, it goes to what? About 1.2, 1.3. So as the systolic blood pressure clinic BP goes from 120 to 170, the risk goes from, let's say, 1 to 1.3. But if you are monitoring that nighttime BP, the top line in green, nighttime BP, and extend that to 170, you see that a 170 blood pressure at night would predict cardiovascular mortality by 3 times higher. So what did we learn? The nighttime blood pressure, like the nighttime cities, predicts and actually reveals their character, reveals a true long-term prognosis. So the nighttime baseline blood pressure shows us the true risk of cardiovascular death. And this has been correlated with diastolic pressure also. So what did we learn? Yes, we saw the pictures of nightlife, in the city is a good predictor. And now we learned that night blood pressure, the night stable blood pressure, which we normally say is 120/70 and below, is a predictor of cardiovascular mortality. So nighttime blood pressure is one of the strongest predictors of cardiovascular mortality. Learn statement number 2. We know that the mask culture has changed, right? Years back, if you had seen a masked man, the image would have triggered the image of a bank robber or a terrorist. But now today, masks have changed. It has settled down everywhere, including people of peace and religion. So has the nature and understanding of what we call as masked hypertension. Some of you might wonder what exactly is masked hypertension. The rest of you might have already known about masked hypertension, but we would go beyond that. Masked hypertension, for the starters, is a high blood pressure where the daytime blood pressure, this is an ambulatory blood pressure graph. The green line is systolic. Look at that. Daytime blood pressure is near normal, slightly elevated, but nothing to talk about. So near normal, but nighttime blood pressure, look at that, is significantly high. So daytime blood pressure is near normal. Nighttime blood pressure is very high by ambulatory BP. So this hypertension is not known to the clinician who is estimating BP during the day. So this is called masked hypertension. Now today we know that masked hypertension has an outcome as bad as a daytime hypertension, because we even worse, because we are not detecting masked hypertension quite often. How do we think about masked hypertension? How do we suspect masked hypertension? When we see patient has target organ damage, albuminuria in urine, left ventricular hypertrophy, history of TIA or stroke, but blood pressure is not very high. We put an ambulatory blood pressure and we find that daytime blood pressure is near normal, nighttime BP is high. It's called a masked hypertension. Now, we have learned a lot about masked hypertension. In fact, just till about a couple of years back, there was hardly any talk about masked hypertension in the Western literature. Because in the West, in the Caucasian population, masked hypertension is significantly lower incidence, about 7 to 8%. Okay, but this is one of the ambulatory blood pressure data that we generated from India, and we are proud to say that we generated from India. And this came in the Journal of Human Hypertension in 2019. And those of you who are unaware, this is one of the largest databases of ambulatory blood pressure in the world. 27,472 patients from India. We did the ambulatory blood pressure measurements and found that masked hypertension amounted to 19.3%, almost 20%. Right? So 1 in 5 patients whom you see has masked hypertension. Is that common? Right? Okay, so masked hypertension is common. I think till this amount, everybody knows this data. But let us take it a little bit forward. The next interesting point came from a study that came in JACC about 2 years back, comparing chlorthalidone, a newer diuretic, to hydrochlorothiazide. Nothing that we are talking about today. Chlorthalidone versus hydrochlorothiazide. And they showed that if you look into the office blood pressure reduction, the blue is hydrochlorothiazide and the red is chlorthalidone. This is almost same. Red and blue bar, the coming down of blood pressure, fall in systolic blood pressure, almost same. But when we looked into the nighttime blood pressure, we found that the hydrochlorothiazide in blue was far poorer compared to chlorthalidone in reducing blood pressure. So they just wanted to say that nighttime blood pressure was better brought down by chlorthalidone compared to hydrochlorothiazide. But we are looking at something else in this study. So look at that 2 drug combination. Now forget about chlorthalidone, forget about hydrochlorothiazide. Let us say we are giving a good drug to our patient, and looking at his blood pressure in blue. Patient number 1 in blue. Look at his ambulatory blood pressure. The top straight line, 0, is the standard line, above which is abnormal. Now look at that blue line. The blue line from beginning there till entire day end, you see it is always below the baseline, right? It is well controlled. So blue patient is well controlled 24/7. Now look at the red drug. Let us say it is a short-acting drug. Let us say we are giving the patient a short-acting nifedipine capsule, 5 milligram. Okay, the patient's blood pressure drops. He goes home. But look at that. If you look at his later part at night, I've circled that, between 10 p.m. and early morning 4 p.m., surprisingly, you see that the blood pressure has at night has gone up and gone to that level. Obviously, because the drug has stopped acting. So short acting drug at the fag end of its action, the blood pressure has gone up. Nothing rocket science behind it, right? But the point is, you and me, we are estimating this patient's blood pressure here in the clinic at 10 o'clock or maybe 11 o'clock or late 12 o'clock. So whether this patient was taking a blue drug, which is a good drug, or a short-acting red drug, we are happy. His blood pressure is controlled. We'll tell you, chalo, you are fine, you are okay, good. But his night blood pressure is high. So the red patient has got iatrogenic masked hypertension, whereby we have converted his sustained hypertension to a masked hypertension by controlling just the daytime BP. But you might say, oh, at least we have controlled the daytime BP, right? At least we have controlled the daytime BP. But let us see what happens if we just at least control the daytime BP and convert a patient to masked hypertension. And that was taken up by this paper of masked hypertension, understanding its complexity. It's a very interesting paper that came from Netherlands in the European Society of Cardiology journal. They looked into all the published data and found something very interesting. Okay, the x-axis here is the follow-up years. And you see this is a data of 16 years follow-up, right? 16 years follow-up. And what you are looking at is cardiovascular events in the y-axis. Now, if you look at all the different categories of hypertension, the orange category is the one which is a short-acting medication has converted this patient into a masked hypertension, or what we talked about, iatrogenic masked. Compared to even a usual masked hypertensive, a normotensive, or a usual essential hypertension, this group has the worst outcome. So if you get a sustained hypertensive patient and control his daytime BP with a short-acting drug, you produce the worst outcome, which is even worse than not treating at all. Now, why that occurs? That occurs because we are creating more variability. We are controlling the normal blood pressure during daytime, but the night blood pressure is high. Body doesn't like variability, right? So body doesn't want variability. Anything that will produce artificial variability has bad outcome. So compared to all other categories, the orange in iatrogenic masked has the worst outcome. So if we have learned something, that is what a bad outcome is, a conversion of sustained hypertension to masked hypertension by suboptimal therapy. So don't use suboptimal therapy, right? Because, I think the philosophy is simple. Philosophy is simple. We also talked about, how suboptimal hypertension control can worsen dementia or create or accelerate dementia in the Indian context. That was a review article that came in Journal of Human Hypertension, Nature, in 2019. But this is important to understand the philosophy. See, we know that the present pandemic, for example, came from bats, right? COVID came from bats. Whether it came from the wet market in Wuhan, or whether it was engineered at the Virology Institute, is a question of debate. We are not going into that. We are not going into such debates. But the point is, whenever you see nature producing something, it is far more gentle by design. Gentle by design. For example, anticoagulant-induced bleeding. A patient who gets intracranial bleeding, something else, he may still survive. But take an overdose of anticoagulant, warfarin, or NOAC-induced intracranial hemorrhage, it is far worse. Consider diuretic-induced hyponatremia. Consider NSAID-induced AKI or a stent thrombosis, right? An ACS, a patient not recognizing at home, may still survive. But a stent thrombosis might result in an instant bad outcome. Okay, infection of an implanted cardiac device. So anything that gets complicated by intervention of humankind is far worse than nature. Nature is gentle by design. Same thing is for iatrogenic masked hypertension. So you've learned something. Point number 2 is iatrogenic masked hypertension created by us by giving a short-acting suboptimal drug has bad outcome. Point number 3, the new vistas to learn is, if you read Malcolm Gladwell and read his book Outliers, he says, what does it take to become successful in life? Whether you are an academician or a boxer or a dancer or an archer or an ace Olympian or a whatever profession you are, he says that it takes about 10,000 hours of deliberate practice to become an expert, nothing else. You do the same thing 10,000 times, you become an expert. Like Bruce Lee once said that I'm not worried about 10,000 different kicks, but I'm worried about one person who practices the same kick 10,000 times. So 10,000. So practice makes it more important, and you are an expert. So it is important that we follow or keep in to a target on which we are focusing, right? And that brings us to the change of concept from variability. You might have heard so many lectures on variability in blood pressure, but now we are shifting from variability to time in target therapeutic range of blood pressure control. So you might say, what are we talking about? In India, we know that only about 7%, 8% of patients today are controlled at goal. We're not talking about control at goal. We're talking about a new concept of time in therapeutic range or time in target range of control of BP. What exactly is it? Now, if you say that is a normal straight line, red line is a normal blood pressure of 120. Let's say we are taking 120 as a normal blood pressure. And our patient's blood pressure starts there at some 160. I've given him a medication and is brought down to 125. Right. So good control of BP. I'm happy next time. But has he reached target? No, he's still above 120. A second situation can come where the blood pressure that is a straight line of 120, patient is remaining at 130 or 120 and now brought down to 110. Good control. Okay, this patient is well controlled. Or maybe even flat, where the patient is still controlled and it has not dipped. Another situation can be patient has that's 120, patient has 130 blood pressure. With drugs, it has come down to 110, controlled. Okay, this patient has reached control. And of course, another can be a patient who was 120 or 110 has now gone to 160. Now understand this, of all the variabilities, only the right top panel, the patient is continuously in target. So that is what we are talking about, being continuously on follow-up in target range. Like we talk about the target range in anticoagulants of PTINR, what we today talk about the range of glucose control, we are talking today about the time in range in target or therapeutic range. So how long my patient is spending in the therapeutic target range? How long? Not that he has just got control, he is staying in that target for long. Now, is this important? Now, this paper came in this year, as you can see, the date 2021, which looks into systolic blood pressure, time in target, and cardiovascular outcome in hypertension. So it was simple. What they did was, as they followed up patients, they kept a track of every review, how his blood pressure is, and next review, are they remaining in target, or in between, are they going off target? And then they found something very interesting. They divided the groups into 4 categories. Target or TTR, 0 to 25%, 4 quartiles, 25 to 50, 50 to 75, and between 75 and 100. Those patients who kept between 75 to 100% in the target range, so mostly they were in target. In them, surprisingly, that the baseline data, it turned out that their 10-year atherosclerotic vascular disease ASCVD score is the lowest, and that is statistically significant. Obviously, you can say, yeah, they are the patient who are careful and they have kept their ASCVD levels down, and that's why they did better. This is at the end of the study, right? So these are patients who did well. This is not end, but this is the baseline study. So these are patients who did well, right? Now, what was surprising is here, when they followed up these patients and calculated What would happen if the time in treatment range increased by 1 SD, and what would be the impact on people's MACE, for example? They found that if they are keeping in range, the benefit is what? 0.81. That is 20% reduction of MACE and 25% reduction of non-fatal MI. So the highest quartile versus the next quartile has a difference of 20% reduction of MACE and 25% reduction of non-fatal MI. Okay, and that is significant, right? Now, understand that this data, what we talked about, is a subset from the sprint trial, right? It's a subset from the sprint trial. So any study subset that we take out without planning for it obviously has much less statistical significance. And that's why you saw that even at baseline, the group that tended to remain in the therapeutic range, 75 to 100%, they had lower atherosclerotic vascular disease. So this might be the reason why they did well, right? But what is surprising is that to follow this concept out, this trial came in. This is the Caliber data that was done with a base at London, covering entire of European Union. And this data came again this year in the Journal of Hypertension. Very, very interesting. Talks about the time spent at blood pressure target. Now, the sprint data is a smaller comparatively because it's a subset, those who are followed up for the time in target. But this data set, for example, looked at death and cardiovascular disease is huge, right? So this Caliber registry included 169,000 patients, 169,000 patients. And the number of blood pressure recordings were 1.6 million. So 1.6 million follow-up visits in 169,000 patients, and a very carefully done registry. And in this registry, they found that at a median of 4.9 years, 5 years, there was an event rate of 3.4%. And that constituted about 400 of cardiovascular death, myocardial infarction, 318 heart failure, 1526 stable angina, peripheral vascular disease, death from any cause. But what is surprising is that when they looked into the long-term outcome, this is interesting. When they looked into the long-term outcome of cardiovascular death, heart failure, any cardiovascular disease, stable angina, peripheral vascular disease, or all-cause mortality, whatever, they looked at all these 6 outcomes and put them in tertiles of from those who were not in target range, or in 25% target range, 50%, 75%, or 100% target range. And if you look at the data, look at that. As the people were going into more and more therapeutic target range, their cardiovascular death and MI and stroke gradually tend to come down and become lower and lower, deviating from the straight line. So if you keep your patients' time in target well under control, you get benefit by reduction of cardiovascular death, MI, stroke. Same for heart failure, same for any cardiovascular death, same for stable angina, same for peripheral vascular disease, and even a tendency for all-cause mortality. So suddenly, we have found a parameter which we were never looking into. It is a time that the patient spends in target therapeutic range. So if we say target therapeutic range is below 130 systolic, how many times, we are not talking about one day, every visit, during the visits, how many times he spends in the therapeutic range. And that is converted into a complex algorithm formula, into a percentage to find, is he mainly remaining in therapeutic range or not? Exactly like the PT-INR that we do for our patients on anticoagulants like warfarin, right? Now, when they collected that data of Caliber registry, that 169,000 patients, and looked into all predictors of outcome. Okay, for example, they looked at variability. We talk about variability so much. They found that if a person's variability is controlled, the reduction of hazard ratio is what? 2%, 0.98. But if a person is in 1 year, at least a 6 to 8.9 months, if he is kept in the target zone of blood pressure control, The hazard ratio is 0.27. That means what? 73% reduction of event rate. And if he is mainly remaining in control between 9 and 12 months, the hazard ratio is 0.17, meaning that what? 83% reduction of event rate. So today, suddenly, compared to target organ damage, left ventricular hypertrophy, history of stroke, or any other parameter, or even the degree of blood pressure, one important parameter has come in, which we need to focus, is time spent in therapeutic zone or time spent in target of blood pressure control. So if the patient in every visit, 1, 2, 3, 4, 5, 6 in a year, his blood pressure is in the normal target range, versus the patient whose 3 were in normal and 3 are abnormal, or the first 3 were abnormal, last 3 were normal, they have a far worse outcome. And that is a new understanding. But this data puts it into a problem. You said that, okay, are we barking up the wrong tree? Are we barking up the wrong tree? Because in India, only about 8% people are controlled. Okay, 30% to 50% patients of hypertension are unaware they have got blood pressure. Of them, about half don't even go and see a doctor. Okay, of those we prescribe medicine, 50% don't even take the medicine. So are we talking about something that we can't even see and control? So how can I, in Indian context, control night BP? I don't have access, let's say, to ambulatory blood pressure. How can I make sure that I'm treating masked hypertension well? I don't have access to ambulatory blood pressure. How do I keep time in therapeutic range for a patient? Because, a patient may not come back. How do I know? So the answer to these three questions is simple. If you have a well-designed combination pill, which we'll show you in a moment, if you have a well-designed combination pill with you, most of your patients, at least a large number of your patients, are likely to achieve a good nighttime BP control, avoid masked hypertension, and keep more often in the target therapeutic range. We will show you how. So the one point why the European Society of Guideline 2018 talked about one single pill in hypertension is mainly because they had compliance in mind, right? So they said that any hypertension, you start with a combination, not just one drug, because one drug generally don't control hypertension. So give them either ACE or ARB, a RAS inhibitor, plus a CCB, calcium antagonist, or a diuretic. Okay, so ACE or ARB with a diuretic, or ACE or ARB with a CCB, calcium antagonist. If it doesn't work, combine in one pill altogether, ACE, ARB, CCB, diuretic. Okay, and if it still doesn't work, you add up the spironolactone and whatever you want. So that brings us to the point that, okay, we understand that most people need a combination. Which combination should be there for India? What combination should we choose for India? The answer lies here. We have 65 million diabetic. And today we know that we need to choose our drug depending on the comorbidities that a person has. And if somebody has a renal impairment, has metabolic disease like diabetes or dyslipidemia, probably the best drug is a renin-angiotensin inhibitor, right? So 65 million diabetic. And what we don't see is this. We have 80 million pre-diabetic waiting to become diabetic. And they have a higher risk today, as we know, compared to people who are not diabetic at all. So 80 million pre-diabetic, 65 million diabetic. And if you have seen the recent ICMR India study data, with Dr. Shashank Joshi published, 79% of urban Indians have at least one abnormality of their lipid profile. 80% of urban Indians have at least one abnormal lipid parameter, be it a low HDL or a high triglyceride or a high LDL or a high non-HDL cholesterol. 80%. So you add up this high incidence of dyslipidemia and high incidence of diabetes and prediabetes, we obviously choose a RAS inhibitor. Okay, RAS inhibitor, ACE or an ARB, right? Now you might wonder, why have we written ARB? We can write ACE inhibitor as well. Actually, ACE inhibitors have very strong data in metabolic background. Now, the point is here. See, the importance of compliance comes in whenever we treat a disease like hypertension, because it is asymptomatic. A hypertension patient has no symptoms, right? So he comes to you, you give him a drug, and if he gets some problem, what he will do? He's likely to drop off medications. Not just medication, he may not visit a doctor anymore at all, because he would say that I did not have a problem. This doctor gave me a medication that gave me so much of a problem. What problem? See, I started coughing with that medication. See, I started getting worsening of my asthma with the medication, beta blockers, right? ACE inhibitor induced cough, beta blocker induced bronchospasm. The calcium antagonist gave me pedal edema, and that diuretic made him hyponatremic. He will never ever take a medicine and go to a doctor, especially in India. So patients are likely to default. So in a disease which is as asymptomatic as hypertension, this is different from heart failure. A heart failure patient, whether he has cough, whether he has got pedal edema, whatever he is, he will continue his medication because he has a symptom. A hypertensive patient has no symptom. So the moment he gets a side effect, he is likely to default. And that is the very reason why all the compliance studies have shown that compared to ACE, ARB, CCB, diuretic or beta blockade, ARB stand out. This is the 1 year data of compliance. 65% of ARB patients continued the drug because it had a placebo-like side effect. And that's why we always say that when we are talking about a combination of compliance and metabolic problem, so metabolic derangement and compliance, especially in India, poor compliance, we see that ARB stands out. Just because it is the most compliant drug and because it is good for metabolic derangements. Now, and in that, when we try to choose which ARB, obviously we try to choose one which has a long duration of action. Okay, for example, telmisartan, as we are talking here, has a half-life of more than 24 hours. Every drug, shorter drugs have their own benefits, longer half-life have their own benefits. Benefits of long half-life is what? Even if the patient has forgotten to take next morning pill, the blood pressure surge, it will not be sudden, but it will slowly go up so that he has time. There will not be a sudden rise of blood pressure when he stops medication, number one. Second thing, you can take the pill once daily. So telmisartan has a very long half-life. So the point is that one drug, let's say we are talking about now telmisartan or ARB, will obviously not do. This is a slide that everybody has seen. Data from Wikipedia, ABCD, MRD, HOT, ASK, IDNT, where we have seen that in all these trials, every patient needed more than 2 drugs and majority needed 3 drugs. And that's the reason why European Society has said that you need to combine at least 2 drugs. So let's say ARB plus CCB or ARB plus diuretic. So you might say, which one? Take a little break and look at the population growth rate in India. Nothing to do with hypertension, right? We are not talking about the absolute population. We know that the population always grows. We are talking about the population growth rate. You will be surprised to know that the population growth rate in India, the blue line, is actually dropping. Since the 1980s, it slowly started dropping, and now it is going down. Not the absolute population number, but the growth rate. But if you look at that red line on top, the elderly population from 2000 is increasing. Why? Better health, higher life expectancy at birth, better medical care, and their life population is increasing. So what is happening? India is becoming a top-heavy country where we have more elder patients like the West and lesser number of true growth rate. But that leads on to people like this more in the society, and they need to be treated gently. And when we are talking about isolated systolic hypertension of the elderly, the large volume of whom we have here, we know that calcium antagonists and diuretics are one of the best group of drugs for this group of people. So if we are thinking of a combination generally, we first tend to choose an ARB with a CCB. And of course, if the patient is volume overloaded, we think of an ARB with a diuretic. Now, one more reason why calcium antagonists came into the forefront, but this article that came in 2010, 10 years back, by Rothwell et al., whereby suddenly it shot calcium antagonist into prominence, and that is blood pressure variability. They showed in a unique long-term trial that if we look at different drugs, CCBs, diuretics, ACE inhibitor, ARB, beta blocker, the calcium antagonists had the lowest visit to visit variability. This is 2010. There was no concept of time in target. Now think about it. What exactly is visit to visit variability? And what is time in target? Basically same. It's just that time in target is a more sophisticated measurement of blood pressure variability. It's a more fine-tuned element, fine-tuned tool to find variability, right? They're same. So CCBs have one of the best profiles to control blood pressure variability, and perhaps in combination keep the target time in range for more and more patients. So with that background, take a moment and look at the 2020 ISH guideline, the International Society of Hypertension guideline that came just last year. Same as the European Society, same. So they said ideal combination is fixed drug combination of at least 2 drugs. But in the stage 1, they said that you can start with a low dose of 2 drug combination. Okay, so they said ARB or ACE inhibitor with a calcium antagonist, so A plus C. If low dose doesn't contain, go to high dose. If still not, go for triple drug combination like ESC, RAS inhibitor, ACE or ARB, CCB and diuretic, and then of course combine all 3 plus spironolactone. But look at a pattern. I think you've already seen that, right? What is it? If you see in every stage, step 1, step 2, step 3, and step 4, there is ACE or ARB with a calcium antagonist. So RAS inhibition with an ACE or an ARB, we are now talking about ARB because of the compliance advantage. We are talking about ARB because of the huge metabolic derangement that we have in India. Piggyback to a long-acting CCB looks ideal even by the ISH 2020 guideline. That is why everywhere, in every stage, you see A plus C, A plus C, and A plus C, even in resistant hypertension. Right. Now, with that background, just look at a peak of cilnidipine, the combination that we are talking about today. We know everything about cilnidipine. We write cilnidipine so often, but understand that this is one of those articles that came showing about 560 patients from Japan about blood pressure control on giving cilnidipine. Nothing great about it. Stop there. But there is a point. The point why we showed this, not to show that, okay, the dark triangle and the dark circle in cilnidipine is a better control. No, but the point is, look at that. The night blood pressure is also lower systolic and diastolic with cilnidipine when compared to other CCBs. So what are we talking about? Cilnidipine, by inherently, is a good lowering agent for nocturnal blood pressure. We have data on that, right? So nocturnal blood pressure is well controlled with cilnidipine. Okay. Now with that background, we should understand that today we know so much about calcium channels, right? When I was a student, there was only one calcium channel understood. Today we know that we have an L channel, which stands for long-acting, long-lasting channel, which is inhibited by nifedipine, amlodipine, diltiazem, verapamil. We have the N channel, what we call the neuronal channel, right? And for example, drugs like cilnidipine control the L channel and the N channel. And of course, the T channels are the transient current channel, which are called the T channels in calcium channels, are controlled by benedipine and aznidipine. They are L and T blockers, right? Now, if we look into the chart and look into L and N and T, what do we take home? Basically, they are all calcium antagonists, right? One difference that stands out from L channel blocker alone versus the LNN and LNT is the reduction of heart rate. And of course, reduction of intraglomerular pressure. Being a cardiologist, I will not talk about intraglomerular pressure today. We'll focus on heart rate. So there's a tendency for these drugs, the newer calcium antagonists, not to raise heart rate. Okay, so are they important? Most of us, we truly feel that perhaps it is more theoretical and it is less important. Now, look at that. This is what calcium channel antagonists do? L channel antagonists inhibit the calcium channel on the blood vessel and produce and prevent vasoconstriction and produce vasodilatation. But we forget that there's a huge other story that is hidden with the newer calcium antagonist, and that is the N channel. The N channel is situated on the presynaptic neuron of any adrenergic of any nervous system, and that is activated by a calcium channel and inhibited by a calcium blocker. Which means if we are using a new calcium antagonist, one of these which are L and N blocker like cilnidipine here, we in turn reduce the norepinephrine release by the adrenergic nerve fiber into the synapse. So if we use theoretically cilnidipine, it has a calcium antagonist effect, plus it prevents secretion of norepinephrine into the nerve synapse. What does it do? So it prevents vasoconstriction, it reduces heart rate, and of course reduces intraglommerular pressure. So we are focusing on reduction of heart rate. Now you might say, like all of us say, that this is more theoretical and perhaps this has very little practical implication. But hold on for a moment. Now the CA Attend study, which again came from Japan recently, shows something very interesting. It shows the effect of cilnidipine on reduction of blood pressure in the top graph, both clinic BP, morning BP. They were trying to say the effect on clinic BP and home BP. And yes, it is reduced. They looked at diastolic BP. Yes, it is reduced. But let us focus on the third group, that is the pulse rate. Whether we look at clinic BP, the morning home BP, or the evening home BP, we see from 0 time to 12 months, progressively there's a tendency for the heart rate to come down. So there's a tendency for the heart rate to come down. This is in contrast with any calcium antagonist that produces a vasodilatation that reflexly increases heart rate. Unless, of course, you block the heart rate with a beta blocker. So the heart rate tends to increase with usual calcium antagonists, but with the newer calcium antagonist, the heart rate tends to be a little bit slower. Now, does this really happen in practical life? Now, this is a trial, for example, which tried to look into the effect of cilnidipine versus amlodipine on ambulatory blood pressure. As you know, ambulatory blood pressure, all today's ambulatory BP, gives the heart rate at the bottom, a line that shows the heart rate. And this data also showed that, okay, blood pressure control on the left panel. But if you look at the heart rate with amlodipine from 0 to 48 weeks, there is a slight rise. Yes, so any calcium antagonist producing vasodilatation, there's a slight rise of heart rate. But in the cilnidipine group, you see a distinct drop. The drop may be few beats, but there is a distinct drop of heart rate. So there's a little drop of heart rate, or at least reduction of the rise of heart rate with the newer calcium antagonists like cilnidipine. You might say, does it really matter? See, last year we published one of the largest data of blood pressure from India, which we termed as India Heart Study. We, with about a dozen and a half of our colleagues, we did it pan-India. And this was a large study, which looked at self blood pressure measurement in India. In fact, home blood pressure monitoring in India, this is one of the largest data sets. It had 18,918 patient data, whereby patients recorded blood pressure at home, and we looked into their data. What came out as a surprise was that the resting heart rate, the instrument also looks at resting heart rate, in Indian patients was 83 beats per minute, which is significantly higher than the Caucasian population. So remember that we are finding two distinct differences in the Indian population versus Caucasians. One is we have more masked hypertension. Second, we have a higher resting heart rate. Now this, after we published this, had been under intense debate as to how this translates onto practicality. And to be honest, we don't really know. But all that we know, that the Indian patient has a faster resting heart rate, RHR, is faster. Okay. And we know worldwide data indicates that even when the BP is controlled, I repeat that, if the heart rate is fast, we have large data set to show that the effects are not as good. So a person with a controlled BP and raised heart rate is almost that like a person with a controlled heart rate and normal BP. So we need to control heart rate and blood pressure. And that's why the very question came in after this data that should be upgrade, for example, beta blockers in the algorithm of treatment for India. The answer is we don't know. We have never tried that. Okay, but if somebody gives me a drug, a calcium antagonist, which does not raise heartbeat in this population, or something that at least tends to lower heartbeat practically, well, probably that might be my take because it is likely to give a benefit to our patients. Now we end up with one short presentation of a series of slides that came in 2020 November at the scientific sessions of the American Heart Association. Now this is a data which is called a TRUMPH RCT registry, whereby they looked at a triple, not double, a triple drug combination on time at target. We have learned about time at target, or time that the patient spends on the therapeutic range, right? They tried to see this time at target an effect of 3 drugs. Wait a minute, why are we talking about 3 drugs? Now in this trial, they tried on they tried patients who had more than 140 blood pressure, 140/90. They were put in either triple pill combination, 1 pill with 3 drugs. Okay. And the other usual care. What is this 3 drug combination? That was telmisartan 20 small dose, amlodipine 2.5 small dose, and chlorthalidone 12.5 small dose. So the idea was small dose of multiple drugs at the baseline itself might be better in keeping the patient at a target range compared to usual care where we give one drug, gradually increase, add another drug, try to control. And this data came from Sri Lanka. So why it is important? Because it reflects similar kind of ethnic, cultural, social, and economic background like India. Okay, so that's what we were saying, that we might not have access to a very high level of investigation like ambulatory blood pressure or an echocardiogram for everybody. But if you have a strategy that at the beginning I am giving a 2 or a 3 drug combo, and does it do good to the point that we are discussing, night BP, masked hypertension, targeting range? Let us look into the results. Now, this data shows that there are patients like what we see every day, coronary artery disease, where only about 10%, but hypertension, diabetic 30% in this data, CKD 1 or 2%, smoker 10%. And they found that when you look at the systolic blood pressure on the left or the diastolic blood pressure on the right, okay, the orange line is triple drug compared to the usual care. At the end of 24 weeks, had a better blood pressure control. Obviously, you are giving 3 drugs compared to 1 drug and checking, patient had a better blood pressure control, both systolic and diastolic. Okay. Now, what is even more interesting is this. When they looked into the follow-up data of how much of time these patients spent in the time in therapeutic range, they found that it was far more common in the polypill group, which is 64% compared to 43 in the usual care, and the value was 1.39 with a p-value which was significant. So obviously, if you start your patient with a combination pill, whatever you are choosing, you have a higher chance of keeping the patient in therapeutic control range over a long term, even if you don't have access to complicated testing. And not just that, they saw that if you look at those who had spent 50% of the time in target range, in fact, the sprint data and the caliber data showed that at least 50% of the time, if your patient spends in target range, their outcome tends to be good. So let's say you're following up your patient 6 times a year, 1, 2, 3, 4, 5, 6, even in 3 visits, if you see that mostly he's in range, it is better than not being in range at all. Of course, the best would be all 6 in range. So more than 50% in range, what is called a tighter time in therapeutic range, was seen in 64% in the triple group compared to the blue bar, which was only 36% usual care. And not just that, what they found was that if you look at the timeline, 6 months, 12 months, 24 months, As time continued, despite the usual group, the doctors are hiking the medicines. But there was a tendency for the polypill, the triple pill group, to have a better control 6 months, 12 months, and 24 months. So it is just like that, fill it, shut it, and forget it. So in a resource poor country like India, the strategy could still be starting on a good combination therapy. So the patient has a better night blood pressure control, lower chance of masked hypertension, and a higher time in target therapeutic range. So in conclusion, ladies and gentlemen, what did we learn today? Number one, night blood pressure is a very important prognostic indicator of mortality. So night blood pressure by an ABPM is very important predictor of cardiovascular events and mortality. Number two, iatrogenic masked hypertension is bad. It's not that patient has a nocturnal hypertension, but I am giving a short-acting medicine, which is acting only during daytime, giving his blood pressure normal. He's taking it in the morning. When I see him in clinic, it is normal. But at night, his blood pressure is still high. So sustained hypertensive converted to a masked hypertensive by my treatment makes the condition even worse. And they have the worst outcome as shown in the ESC data. Point number three, time in therapeutic range is extremely important. It's just a concept that most of the time when you follow up, patient should be in the therapeutic control range, which is important and which is logical, right? And if we don't have access to all this, which is there for most patients, a combination pill early started might attain BP goal, time in target, and control night blood pressure, which could be a good strategy. So the point is, all these years we were talking about that a combination pill is more acceptable to the patient. A combination pill might make the patient take it more often because he's taking just one pill. He may not forget his pill. But today we are talking about a totally different scenario. We are talking about better control of night blood pressure. We are talking about unlikely or less likely for the patient to have iatrogenic masked hypertension. We are talking about patients spending more time in therapeutic range, which is a very important prognostic marker. So finally, it would be that choose the combination wisely. We end with one simple message that do take care of your health and be safe, because this is bad time. And when we are talking about take care and be safe, we are just not talking about how you look like in a Zoom meeting or your virtual shape, but the people